So in this lecture, I want to discuss pharmacological management of orthopedic and neurological populations within the home health setting. This lecture is not going to encompass blood thinners, as you'll commonly see in postoperative cases, just because I want that to be discussed more in a video specifically directed towards cardiac populations or cardiac medications. For now, as a brief disclaimer, since medications are pretty agent-specific, side effects always vary, so consult with the prescribing physician before advising your patients to make any change to their medications. When you're in doubt, you can always refer to the medication labels for any questions you might have. And as far as my standing, I'm not a licensed pharmacist or physician. The content of my material comes from my education as a doctor of physical therapy, not a doctor of pharmacology or allopathic medicine. Just an overview of topics to come. I'll discuss opioids or narcotics, non-opioids, antispastics, antispasmodics, benzodiazepines, dopamine replacements, antiepileptics, and biguanides. At the very end, I'll discuss briefly a couple others like cholinergic drugs and some others. But to start, for opioids and narcotics, these are primarily used to address higher levels of pain, and you'll commonly see Oxycontin or roxicodone, aka oxycodone. There's also Pavaril or codeines, Ultram or Conzip like tramadol, morphine, aka Roxanol. There's Sublimase or fentanyl, Demerol or mepridines. The side effects for these and their implications do vary, but first I want to give you a quick thing on morphines. So morphines or Roxanol is commonly indicated by brand names with the stem or affix of morph. So if you're doing a medication reconciliation, you see things like Duramorph or Infumorph, Astromorph, Morphobond, so forth. Those are good indicators that this is perhaps a narcotic medication. Those are all forms of morphine medication. But going back to the side effects, so I have a list: sedation, orthostatic hypotension, reduced coordination, constipation, dulled cognitive function, physical dependence. So why exactly are these substantially important for the physical therapist to know in this setting? Sedation, starting with that, if your patient's on the brink of falling asleep during your visits with them, it's perhaps because of the heightened effect of the Norco or hydrocodone they're on, and maybe it's peak activation for them as 1 hour after they take it, and you happen to come, let's say 30 minutes after they take their pill. You're at the peak rate where, yes, their pain is dulled, and I understand why a lot of clinicians do want to arrive at the patient's house, have them exercise when their pain is most numbed, and while in some instances this may be appropriate, others it's not. So if they're falling asleep on you, time their medications differently or rotate your schedule to arrive at a different time frame within that peak impact of the medication. With that other mindset, though, there are patients who have increased pain that is just incredible, and in those cases I definitely do wait until their peak medication effect is in place before I have them do the more significant gross motor transfers or exercises like sink squats. For orthostatic hypotension, this is particularly important because we want to teach them in their supine to standing bed transfers, do the log roll first, then wait a few seconds for any lightheadedness or dizziness to subside, then have them sit up. Once they sit up, wait again, dizziness, lightheadedness, subside, stand up, again wait, lightheadedness, dizziness, subside, now they can start going. So keeping tasks very segmented. If they have increased bouts of orthostatic hypotension, remember this is positional, so if they are sitting down watching TV in their recliner for 3 hours straight and then they decide they've got to go to the bathroom, have them first recline up to an upright position. Any dizziness, lightheadedness, let it subside, then stand up, same thing, let it subside, then start going to the bathroom. Obviously not in place to the restroom where they can use the bathroom. Reduced coordination is important because if they're already a fall risk, when they're not on their Norco or narcotics in general, believe that they will be an even greater fall risk when they are on their medications. So always use a gait belt. Constipation is extremely important to wrap your head around, particularly because if they haven't had a bowel movement in the last 3 or more days, this can be a medical emergency. Often when a patient is on opioids, they have a decreased GI motility and they can be pretty constipated. So impaction can lead to various illness or even death in severe cases. Why this is such a big deal is because if not treated, that hardened stool can lead to perforations in the colon or intestinal lining. And then bowel obstructions can also lead to peritonitis, aspiration, type of ulcers. I think they're called stercoral ulcers. But if it's not a complete bowel obstruction, this can normally be fixed with a quick round of Miralax or Docalax. But it does occasionally require more invasive interventions like a distal washout or manual extraction. Sometimes in very severe cases, a surgical resection is probably required. For dulled cognitive function, pay attention to their level of cognition. Don't give them their HEP, their home exercise program, right off the bat when you know they are doped out. Wait for explaining very complicated tasks or concepts in general until they're either not on their medications or what I like to do is go ahead and explain everything to them as you normally would, but then expect to re-explain everything else or everything again over and over and over each visit, because often we do see patients that are just always on their opioids. For, let's see, physical dependence. So physical dependence is, it can be pretty important to also pay attention to, since sometimes you might notice a patient could have anxiety or like a sensation of ants crawling under the skin. You might get like cold chills or start sweating, have a lot of stomach pain or abdominal pain, not true stomach pain. But if, particularly when the MD is in the process of either weaning that person off their codeines or their opioids, or if they decide to just completely cold turkey all of a sudden, which normally physicians do a good job titrating those medications. But understand that these signs and symptoms are not some new progressive disease that the patient's all of a sudden developing, and yeah, just understand it could be a mild to moderate case of just a standard drug withdrawal. In that case, just relay your concerns to the MD or nursing if they're on board, just to see if they can titrate that medication a little better or start titrating if they decided to go cold turkey on that patient. Non-opioids are for lower to moderate levels of pain typically. This can be Tylenol or acetaminophen, aspirins or acetylsalicylic acid. Advil or ibuprofen, Celebrex or Celecoxib, in general, non-steroidal anti-inflammatories, aka NSAIDs, and actually aspirin, Advil, Celebrex, those are actually NSAIDs. Tylenol doesn't actually do anything for pain. I'm sorry, for inflammation. It mainly focuses on reducing levels of pain, sometimes headache, sometimes fever. Aspirin is really good at decreasing pain and acts as a little bit of a blood thinner, and again, it's an anti-inflammatory, so and it can also treat same things Tylenol can, like fever, headache. Advil is a little more substantial than the previous two as far as its pain reduction properties go. It is an anti-inflammatory and it can also reduce fevers. Celebrex is an NSAID, but it's not really known for its anti-inflammatory properties. Those are relatively insignificant. It's primarily just used to treat minor to moderate levels of pain. Side effects and implications for PT. Non-opioids in general don't really impact the patient a whole lot, so they don't really impact our care or the physical therapist in general. The big picture here between opioids and non-opioids is that individuals on opioids typically have more severe side effects, and non-opioids have a little less severe side effects, but they will report a reduction in their pain, so they may not be very accurate in their pain representation. For this reason, we do want to avoid high activities or high impact activities or high stress or strain activities. Clinician judgment is really important to use here. What I mean by high impact activities is things like uncontrolled stand to sit transfers, so I don't want them crashing down in their chairs. Don't do assisted coughs or percussion or vibration. Obviously, if they're in more at-risk populations, like those with osteoporosis, those who are of particular ethnicities like Asian, for example, or gender specific to females, and age is another important factor, so if they're geriatric. So ideally, if you are a female, Asian, super old, and osteoporotic, you're very at risk for fractures, and when you're on an opioid, you have a dulled sensation of your pain, so I don't want you slamming down into your seat or helping you with those assisted coughs or percussions, because I don't want to cause any fracture. I don't want you to cause any fracture, that kind of thing. High strain activities include things like starting yoga for the very first time in their lives, or full spinal flexion where you just bend down to try and touch your toes. Believe it or not, I have seen patients fracture ribs or vertebrae initiating yoga for their very first time. Now granted, those were older females in both cases, but again, clinician judgment's really important here. And as a side note, if anyone was wondering why very popular combination drugs like Vicodin, which is essentially like a hydrocodone plus acetaminophen, wasn't included in my earlier slides, it's because I didn't want to get carried away with throwing every drug known to man on these slides and confuse you as far as which drug goes into what category, because the purpose of this lecture is directed to a physical therapist population as a clinical relevance tool rather than a lecture towards pharmacy students or medical students for allopathic medicine. Other considerations are for non-opioids and opioids alike is to remember that it can be life-threatening to mix certain medications with alcohol, like your morphines or tramadol or aspirin, and even some of the lesser drugs like Advil, Tylenol, gabapentin. And now gabapentin's not really a lesser drug, but it is a drug that people typically forget about. It's extremely important to remember that patients with significant dementia, Alzheimer's, intellectual disabilities, etc. do receive coordinated nursing and or caregiver assistance, because the medication administration is very, very important, especially when they're on opioids like morphine, Demerol, oxycodone, codeines, fentanyls, you name it, just because of the respiratory depression effects that these medications can have, potentially leading to death, especially when you combine them with alcohol. So respiratory depression is a huge, huge consideration with opioids. Not so much for the non-opioids though. If memory or judgment is impaired, like those populations I just mentioned, ensure that they have a very viable medication routine or regimen. Why I say this is because it's unfortunately not super uncommon in the US that poor old granny seems fine and capable, level-headed, but she decides that she forgot that she had taken her medications earlier that day, and she decides to take them again. A couple hours pass and she's forgot she's taken her medications, so she takes another bout. And again, this is more so with folks who have Alzheimer's and other impairments of either memory, judgment, you name it. But then they decide, oh, you know what, I'm going to take it one step further and I'm going to have a nightcap, because red wine before bed is an excellent antioxidant and it's just what the doctor ordered. And then little caregiver or daughter, you name it, comes in next morning and wonders why, old granny hasn't woken up. So get nursing on board in these cases to establish and maintain a very viable medication regimen. Okay, moving on to antispastic agents. These are used for muscle spasticity. So I want to be very clear here. It's muscle spasticity, not muscle spasms. Muscle spasticity is normally CNS in nature, central nervous system in nature. And these drugs target the central nervous system promoted spasticity to decrease that spasticity or hypertonicity. So medications can be like Valium, which is diazepam, Luracil, which is like baclofen, Dantrium or dantrolene, and then there's the common Botox. Side effects and implications for physical therapy can include generalized muscle weakness, and a big one is that, as it suggests, it reduces spasticity. So you want to weigh the cost to benefit ratio in regards to whether or not the loss of spasticity will particularly impact that patient's level of functionality. So what I mean here is some patients rely on their spasticity or their muscle spasms in order to achieve successful sit-to-stand transfers, or perhaps rolling, if it's even that simple. But if the loss in spastic musculature leads to an overall loss in function, we don't actually want that patient to either remain on antispastics, or we don't want them to start antispastics at all. And another kind of off-the-wall example of this is sometimes patients will actually use their spasticity in order to alleviate their bladder. Believe it or not, in these cases it's also really, really darn important to recognize if for some reason they are no longer able to achieve that ability to regimentally control their bladder. Perhaps it's due to an antispastic agent newly introduced to their system. So again, weigh that cost to benefit ratio. focus on the drowsiness or dizziness if it's pretty impactful. If not, no worries. But these are just considerations and conversations you as a physical therapist should have with the patients, the parents, the caregivers if they have any, and of course the physician. Antispasmodics now. So these are more for your common muscle spasms. They typically address a sustained tonic contraction with muscle spasms from the peripheral nervous system rather than from the central nervous system. They also address more musculoskeletal system muscle spasms rather than the CNS like antispastics do. Medications could include like Flexeril or cyclobenzaprine. You might see Soma, which is also known as carisoprodol, something. And then there's also Robaxin, which is methocarbamol. And then for the side effects and implications for physical therapy are pretty similar in regards to the level of drowsiness or dizziness one might receive from those medications. One thing I would like to point out is that some antispastic medications like diazepam, baclofen, dantrolene, they can simultaneously act as a muscle spasm relaxer, thus acting like an antispasmodic. But we don't want to see an antispastic used solely to address the job of an antispasmodic, so like addressing muscle spasms if the patient doesn't actually have spasticity. That would be overkill and quite ridiculous. When comparing antispastics and antispasmodics, as a rule of thumb, antispastics typically have more severe reactions and make people a little more sedate than a usual antispasmodic. Muscle relaxers are a central nervous system depressant, so similar to opioids, we don't want to mix it with alcohol, and if they are on simultaneous central nervous system depressants, we really want to double check with nursing or the MD if they seem a little symptomatic, that they're not overdoing the CNS depressants. So if they're on CNS depressants, check with nursing that opioids, psychotropics, sleeping medications aren't, again, going to overload those patients, because I feel like as physical therapists sometimes we forget to check if they're on sleep medication or psychotropics just because it's not our general area, but those also are pretty big impactors to CNS depression. Another note is to remind patients that their cognitive functioning may be dull or not up to par, so even though they might start feeling really healthy and capable again, now is not really the time to practice driving if they haven't been in a while, and if they, there we go. We don't want them to practice driving if they haven't been in a while, until they've at least weaned off their sedation medications, since they might also have other medications acting like sedatives, like benzodiazepines for insomnia or anxiety, which is not too uncommon, unfortunately, for the home health population. Benzodiazepines. So again, these are typically used to address insomnia or anxiety. Look at Xanax or alprazolam, Valium or diazepam, and then there's Ativan or lorazepam. For a lot of benzodiazepines, realize that despite their side effects being inclusive of very significant drawbacks like suicidal ideation or paranoia, I personally haven't witnessed this a whole lot in my patients where psychological alteration wasn't already present. Then again, my sample size is much smaller than the thousands of people that drug companies had tested the drugs on prior to their FDA approval and their commercial release, so take that with a grain of salt. Side effects that I do see typically involve sedation, memory distortions sometimes, but deficits most of the time, balance and coordination problems, and again, CNS depressant, no alcohol. Same concepts apply. Dopamine replacement agents are primarily used with our patients who have Parkinsonian-like features or Parkinson's disease. We see them on carbidopa or levodopa, perhaps a combination of the two. We call that Sinemet or etacapone. Implications for a physical therapist is pretty much just along the lines of recognize that that person perhaps has Parkinson's. Sometimes going into a home, you might not have been informed on the physician referral that a patient is already diagnosed with PD, Parkinson's disease. So recognizing that a patient perhaps has PD during the medication reconciliation can give you a pretty quick conception on how you might want to modify your educational components or how you want to have them perform therapeutic exercise or therapeutic activity. I'll explain that though in a Parkinson-specific video. Antiepileptic agents. These can be an array of drugs. Primarily they're for reducing seizure activity. Think of your valproic acids or your valproate. There's tegatrol or carbamazepine, and then there's Neurontin like gabapentin, like I mentioned earlier. For this, it's really, really, really important that you sit down with the patient, caregiver, whoever it is, and realize or try and determine what environmental triggers might cause their seizures and establish a preparedness plan, because many patients that have frequent and reoccurring seizures may not want you to call an ambulance immediately, so work with the patient and caregiver to identify what actions you should take based on certain time frames or the type of seizure or the severity of seizure in the event that you are alone with a patient and a seizure does occur. For glucocorticoids or corticosteroids, these can be a variety of steroids primarily aimed at reducing inflammation, and sometimes this can be inflammation from an autoimmune disorder or a dysregulated immune system, like in the case of rheumatoid arthritis, multiple sclerosis, lupus. But it doesn't have to be an autoimmune disorder creating the inflammation. So we can see this in cases like asthma or COPD or osteoarthritis, where it's ill-regulated inflammation, and we can treat that with glucocorticoids. These drugs can also modulate how your body utilizes fats and sugars, and overall, what I want you to know is understand why the patient is taking those glucocorticoids, because if they are taking it for the purpose of an immune suppression disorder, or they have a very, very low white blood cell count, it might indicate that donning a mask to prevent them from getting sick might be pretty important, because we don't want to be the reason they are hospitalized. So wear protective equipment as needed. Again, that's clinical judgment or standing orders from a physician. So this next drug category is Biguanides. They're not actually very common, but they're very interesting. And I did want to talk about diabetes a little bit, so I felt it was appropriate to throw these in for their own slide. These are an oral type 2 diabetic medication that increases the insulin sensitivity one experiences and decreases the glucose sensitivity. So look at metformin or glucophage. Implications for a physical therapist include that you want to see this medication and recognize, okay, this person is a type 2 diabetic, if you weren't already informed on the physician referral or so forth. But patients with type 2 diabetes may or may not be taking injections. So if they're using Biguanides, it's really important to check to see if their medication package has an IR, an SR, or an ER, indicating the timing of release. So IR is immediate release, and SR is slow release, ER is extended release. Slow release and extended release are the same, essentially. But from what I've been informed, or what I've seen on the labels so far for the package of medications, is that the SR, the slow release, and the extended release typically only require a once-a-day administration, whereas the immediate release is more like every 8 to 12-ish hours. So they could potentially take it 2 to 3 times a day. Normally, patients with long-term diabetes are pretty good about their medication regimens. However, for Biguanides specifically, they're typically given to a younger patient, and that patient may not be as accustomed to their medication schedule yet. So this becomes really important when you're noticing signs and symptoms of hyper or hypoglycemia on a future visit, and that can cue you to prompt them to take their medication if they haven't already for that day. Other agents, these being less notable, can consist of cholinergics, disease-modifying anti-rheumatic agents, or barbiturates. For cholinergics, these increase cholinergic synaptic transmissions, and we commonly see this in cases of dementia from Alzheimer's, but we can also see it used in patients with just dementia without Alzheimer's. And then myasthenia gravis. They commonly cause bradycardia, orthostatic hypotension, and a little dizziness. And so be cautious of that. The same concepts of those apply from before. So for orthostatic hypotension in particular, break it up into segments. The gross motor tasks when you're changing position. For the disease-modifying anti-rheumatic agents, these, in my experience, weren't very harped on so much in school, and I didn't really look at them much until I reached the real world, and I realized they encompassed way more than just the gold salts used to treat rheumatoid arthritis, and they're also consistent of tumor necrosis factor inhibitors, or maybe even antimalarials. So these can definitely be very agent-specific as to what signs and side effects they might produce. So I now look at the medication labels for each of them individually, because I don't trust my own memory just because they're so agent-specific. As common as barbiturates are, you'd think they would have been discussed more in depth, but essentially they're used for insomnia, seizures. The main implications here are, for the physical therapist, are that it's a CNS depressant, and sedative, anticonvulsant. I didn't make this its own slide because it's what I've already discussed. Since it's a CNS depressant, the same concepts I've discussed for the other depressants also apply here as well. So for the take-home message, I want you to know that side effects can be very agent-specific. When in doubt, feel free to refer to the medication label, do a quick Google search, maybe ask nursing or the MD if appropriate. Overall, the value and importance of pharmacology, it does vary. Now, the contents of my lecture are primarily aimed at patients who don't receive nursing services, since skilled nursing usually assesses and maintains medications. However, there are occasions, I'll admit, where as a PT, I may be the only provider onboarded, and there are also other times where nursing may only do the initial visit and the discharge visit, and in those cases you might be responsible for all of the medication reconciliations throughout the treatment cycle, and because of that it becomes very important to verse yourself with the basics of pharmacology. Big take home: confirm that stacked CNS depressants are okay with MDs, and advise the patient in those cases not to mix it with any alcohol. Watch for any constipation episodes, so bowel movements not happening within the last 3 days, particularly when a patient is on opioids. And then if cognition, coordination, overall level of cognition is impaired, that's not an appropriate time to start driving again. Hopefully this video helps clarify again the pharmacological management of orthopedic and neurological populations within the home health setting. I'll discuss the cardiac populations in a future video where you'll learn about Lovenox injections and so forth. Alrighty.